Today I'm going to be teaching you about pathophysiology of postpartum hemorrhage and new treatment alternatives for postpartum hemorrhage. So the definition is severe bleeding after giving birth, can happen up to 12 weeks postpartum, accounts for blood loss greater than 32 fluid ounces, and this can happen right after delivery, or it can happen up to 12 weeks like stated. It's more bleeding than normal after a baby, and this can happen in 1 in 100 to 5 in 100 women have postpartum hemorrhage, and it is more likely with a cesarean birth. The classifications is there's two types of postpartum hemorrhage. Postpartum hemorrhage occurs within 24 hours of delivery, but then there is a secondary or late postpartum hemorrhage that occurs 24 hours to 12 weeks postpartum. So the pathophysiology, this is a picture of the uterus that I drew. Normally the uterus contracts and pushes out the placenta. After the delivery of the placenta, the contractions put pressure on the bleeding vessels, and that is where the bleeding vessels of the placenta are. Postpartum hemorrhage occurs because contractions are not strong enough, so the blood vessels continue to bleed. And this can occur in 4 different ways, but this type is the most common, where the placenta is excreted from the body and then there are not strong enough contractions to stop the bleeding. The seriousness of this is it is potentially fatal. You lose large amounts of blood quickly. There's a sharp decline in blood pressure, which restricts the blood flow to the brain, and this can be very serious. And this is the #1 reason for maternal morbidity and death. So these are the 4 risk factors that I'll go into detail, but there's tone, trauma, tissue, and thrombine. So this is tone. This is the lack of uterine tone, aka uterine atony. The uterus becomes soft and spongy, and it is a slow and steady loss of blood. This is where the contractions aren't strong enough, so they clamp the placenta arteries in the myometrium, which is the smooth muscle in the placenta, which is this outer, and that reduces the bleeding. The causes of this are repeated distension, so multiple pregnancies or twins, triplets, muscle fatigue, and unable to empty the bladder. This is the most common cause. This is trauma. Trauma is damage to the genitals, includes the uterus, cervix, vagina, or perineum. This is can occur from incisions from C-section, the baby coming through the vaginal canal, medical instruments like forceps, and this causes a hematoma, which is the hematoma, and that bleeds. Then we have tissue. This is placental fragments remain in the uterus. There are 2 types of tissue damage. This is placenta accreta, which is the placenta doesn't easily separate, and that is what is shown, or the traction of the umbilical cord. This can lead to uterine atony. Thrombine is blood clotting condition. Small bleeds become very serious. This can be genetic or obstetric, and this prevents clot formation. The signs and symptoms. Most common symptoms is persistent excessive bleeding after delivery. There's a drop in blood pressure, which causes dizziness, blurred vision, or could cause someone to faint. An increased heart rate, decreased red blood cell count, pale or clammy skin, nausea or vomiting, worsening abdominal or pelvic pain. Symptoms may look like other health conditions, so you want to see a healthcare provider if you are experiencing any of these after birth. Common treatments: uterine massages, medications, removing retained placenta tissue, repairing vaginal, cervical, or uterine tears or lacerations, packing uterus with sterile gauze, blood transfusion, uterine artery embolization. Also, a Foley catheter can be put inside to put pressure on the bleeds. A laparotomy, which is opening the abdomen to find the cause of bleeding. Uterine compression sutures, which is tying of sealing bleeding blood vessels, or a hysterectomy could even take place, and that is removing the uterus, but this is a last resort cause if nothing else can be used. And then this is the newer treatment option that is, it's called an E-motive. It is used to calibrate blood collection to provide estimated blood loss. So the first thing that we're looking at is early detection and triggering criteria. So those are looking directly at the amount of blood loss, how someone's feeling after giving birth, blood loss, blood flow, uterine. Every 15 minutes is documented on the blood loss monitoring chart. And then they're going to look at blood pressure and pulse. This too. The trigger criteria is clinical judgment, blood loss of 500 milliliters or more, and blood loss of 300 milliliters or more, observation. Next, and then they're going to treat after that, after they figure out if you are having a postpartum hemorrhage or not. So the first treatment option is, like stated, a massage of uterus. So that is when the uterus is being massaged for 1 minute. And then after that, they're going to start using the oxytocic drugs, and that is dilated over 10 minutes plus a maintenance dose. And then after that is a tranexamic acid, which is injected as well. Then we're going to use IV fluids in addition to the oxytocic drugs and tranexamic acid. And then after that is all done, we're going to do an examination and escalation to see, ensure the bladder is empty, evacuate clots, and just escalate if bleeding does not stop, and maybe have to go and perform the laparotomy or uterine compression sutures or hysterectomy. Those are all kind of last option things, but if it doesn't get better with after this E-motive, then those options are implemented. And then those are my references.